Okay, welcome everyone to our webinar. My name is Olivia. I'm very happy to have you all today, especially because we have so many countries all in this room, in this virtual room. And we are very thankful for your time and for your presence. And especially thankful to have our partners with whom we are organizing the webinar today. So we have UCSF, the University of California of San Francisco, with us today, the GC Flower Foundation, the ACOMIN organization in Nigeria, the Hope for Future Generation in Ghana, UNICEF, who is here with us today, and also the Flower Cross Borders for the Malaria Initiative of the Angelica in Angola. And we are also happy to have a presentation by Pratin from Thailand and the Young Muslim Association of Thailand and the Malaria Elimination Initiative in Thailand. So we are happy to have our panelists with us and also our partner who made this webinar possible. And without any more ado, I will hand it over to Cecilia. Cecilia SENOO, who is a member of the Civil Society for Malaria Elimination, the global platform. And Cecilia, we are happy also to have your time today. Thank you very much. So just to introduce you quickly who we are the global network of civil society and community that are united to achieve malaria elimination. And today we have over 300 CSOs members in 47 countries. And our mission is to make a world free from malaria aligned with the WHO mission. And we want to make sure that malaria programs and interventions are more effective, equitable, innovative, inclusive of civil society, human rights based, and gender sensitive and adequately funded. So we do this by connecting civil society organizations into one platform. We also encourage collaboration, strengthening capacity of civil society, promote involvement of civil society in decision-making at all levels, and reinforce the sense of urgency to eliminate malaria, ensure that malaria voices are heard. And all of that is also to advocate for sufficient funding for malaria and allocation of enough funding support for malaria, civil society and community-led intervention. So we hope to continue to promote universal access to existing tools in the fight against malaria. And we also demand new tools and innovative tools that will help the world to accelerate the fight against malaria. And finally, our key role is to keep our leaders and ourselves accountable to make sure that we can all reach zero malaria, because zero malaria starts with all of us. So our first speaker is Kelly Harvard from the University of California in San Francisco. So Kelly worked with the Malaria Elimination Initiative for 6 years. And during that time, she led the development of a report on opportunities and challenges and effective community engagement in malaria control and elimination context. So today, Kelly will present an insight for CSO, government, funders from a report that she was able to do. So Kelly, we are very happy to have you all the way from California. Please, you have the floor, Kelly. Thank you very much.
Thank you, Olivia. I'll turn on my video, and if my Wi-Fi starts going out, please let me know and I can turn my video off. Next slide, please. So hello, everyone. My name's Kelly. I'm very humbled to be speaking to you all today on this important topic. I'll be presenting results from a background paper on behalf of a larger research team. who helped to collect, analyze, synthesize large amounts of rich qualitative data on community engagement. But what I really want to point out is the collective experience and energy on this call today. It's very exciting, and it's very different than where we were 5-7 years ago on this topic. And I am personally looking very much forward to learning from the other speakers today and from each of you. Next slide. Next slide, please. So this figure shows different levels of engagement between public health practitioners and the communities they serve. Moving from left to right, the continuum shows what an increasingly equitable relationship looks like. Traditional approaches to community engagement typically exist on the lower end of this continuum and are implemented in a top-down manner, whereby policymakers and health professionals are designing interventions, establishing objectives, developing action plans. And a major problem with this approach is that national health authorities tend to perceive the needs of communities differently than the communities themselves. When implemented as a participatory approach, community engagement directly involves communities in decision-making, in managing the activities, and in measuring results. And this approach has the potential for several positive effects, including improving program design and implementation, resulting in efficiencies and sustainable results, reducing operational risks by ensuring programs are relevant and responsive to the local context. And these benefits are of particular interest when you consider some of the operational challenges to malaria elimination, like targeting and tailoring interventions to specific populations. In 2015, the RBM partnership called on malaria programs to involve communities in the design and implementation of malaria interventions and innovations. So given all this, community engagement should definitely be a central feature of malaria programming. Next slide, please. However, community engagement is not consistently defined, operationalized, or evaluated. And this has led to a number of different activities, strategies, and programs, all commonly referred to as community engagement, even though the goals and outcomes vary. And this is true across many different health programs. And in the context of malaria, other important gaps have also been identified, such as lack of adequate human resources and capacities related to community engagement, insufficient funding and interest in issues relating to broader health systems, and operational criteria for effective community engagement are also poorly defined. Next slide, please. So we embarked on the development of a background paper in an attempt to address at least some of these gaps by looking for examples of effective community engagement. And importantly, we wanted to examine and learn from other health areas, not just malaria. Next slide, please. We reviewed 10 programs from 7 different health focus areas. We conducted 7 community-based focus group discussions with 69 participants, 56 key informant interviews with program staff, and we also consulted with 12 independent expert reviewers on the first draft of this report. And the key informant interviews, our focus group discussions, and the literature review provided insights on the underlying principles and operational strategies considered essential to facilitating effective community engagement. Next slide, please. Our results indicate the importance of a common definition. We propose that effective community engagement is a participatory process that actively involves community stakeholders in the design, governance, delivery, monitoring, and evaluation of malaria services. Next slide, please. So what does this definition mean, really? We found community engagement is often conflated or confused with strategies like community health worker programs, community-based interventions, social and behavior change communication, or SBCC. But really, effective community engagement goes beyond what activities and strategies are implemented and considers how these activities are designed, implemented, monitored, and evaluated, and who is involved. Next slide. Our case study and literature results indicate there are a set of mutually reinforcing principles that support effective community engagement, including trust and transparency, trust being critical to community engagement. And to build trust, there needs to be prolonged interaction between health professionals and the community. Community engagement should be proactive, continuous, and integrated. Community engagement is often implemented as a one-off activity. Proactive and continuous community engagement that is integrated with other health and development priorities makes a bigger impact. Community engagement should be adaptable, responsive, local. And of course, collaboration and shared decision-making is also critical. It's also important that minority and marginalized subgroups can safely participate in order to identify underrepresented issues, perceptions, barriers, and solutions. We also were able to identify operational strategies that promote community engagement, all of which you are likely familiar with. And in our report, we outline ways to implement the principles from the last slide by building on existing health structures and processes, such as those listed here. Results from case studies and literature indicate that community engagement should be coordinated from administrative units closer to the community level, and that health services should be responsive to the local context. CHWs, or community health workers, health committees, and other community platforms can be better integrated into the health system and encouraged to facilitate deeper levels of community engagement through the widespread use of participatory methods. Next slide, please. So generally, there are strong linkages between the communities affected by malaria and their local leaders, as well as good coordination between national malaria programs and district health units. However, there is often a large operational gap between community structures and district level health service delivery. And it's this gap that undermines the impact of CHW programs, of village health committees, and other community engagement strategies. And it can also limit the impact of malaria services. Next slide, please. So for participatory community engagement to work, the health system needs to focus on building formal linkages between decision-making bodies and the community. Next slide, please. In our paper, we propose a potential operational model for community engagement. And this model reimagines the roles, responsibilities, and relationships between national malaria programs, district health units, and community platforms. Here, the community and district work together to identify challenges and implement solutions. The district feeds community-level feedback to the national program, and the national program adjusts policies and strategies in response to that feedback. We recognize that this model relies on relatively weaker components of the health system, including district health units, which often lack the capacity to execute the technical and administrative tasks already required of them. But in order for malaria elimination to succeed, it's time that we start working on some of these very difficult issues. Next slide, please. So we set forth some recommendations for national malaria programs and their community partners, such as linking community platforms with the health system, coordinate routine community engagement from administrative units closer to the community, and training national malaria program staff, middle managers, frontline staff, NGOs, and community representatives on participatory tools and techniques. Next slide. We also propose recommendations for funders, including the incorporation of the new UNICEF minimum quality standards and indicators in grant development guidelines, anticipating realistic time and costs associated with implementation and allowing for flexibility in the use of funds, and ensuring that community engagement strategies are not only described in funding proposals, but are also represented in the actual budget narrative and M&E frameworks. Next slide, please. So I just want to note that when we started this research way back in 2017, the landscape looked quite different. And there's been many different areas of progress. UNICEF published the first ever global minimum quality standards and indicators for community engagement in 2020. The WHO is creating a community engagement framework for the first time. Global Fund's technical review on community system strengthening was updated in 2019. Design for Health launched in 2018, which is an initiative to increase the use of human-centered design as an approach to improving health. And of course, CS4ME was launched in 2018. So a big thank you to all the key informants and focus group participants, to the organizations that agreed to be featured in our report, and our expert reviewers. And of course, thanks to all of you for listening to me present on this research. Thank you.
Thank you very much, Kelly. Thank you very much. This was great.
Thank you very much. Cecilia is on now. I'm very sorry. Unstable internet. Hello, Olivia.
Yes, go ahead, Cecilia.
Thank you very much, Kelly, for the nice presentation. Very insightful, very knowledgeable, very informative. We are very grateful. Please put your questions and your comments in the chat box as a reminder. Our next presenter is Rania Elessawi from UNICEF as the Communication for Development Specialist. Rania supports the development and provision of technical guidance for enhancing social and behavioral change, quality programming in both development and emergency humanitarian contexts. Rania has been with UNICEF for nearly 18 years, based in Egypt, Afghanistan, Liberia, India, Yemen, Sierra Leone, and now in the US. She has led the development of several cross-sector interventions on topics ranging from water, sanitation, and hygiene as WASH to the West African Ebola crisis. Today, she will be sharing UNICEF's minimum quality standards and indicators for community engagement and how this material can be helpful to CSOs, government, and other organizations in their own way. So, Rania,
Thank you so much, Cecilia. I will turn my video on just for the quick introduction. And just to say to everybody, I'm really pleased to be here. Thank you so much for offering this time and the space to this platform to be among this wonderful group of speakers as well as peers in the network. And so I'll jump right into it, not to waste any more time. Next slide, please. Next slide, please. So I'll be presenting on the community engagement minimum standards and indicators. And just to clarify the position of UNICEF, while we published and led the process for the development, we really want to recognize that this is an interagency document that is intended and developed from the inputs of multiple stakeholders and actors, and I'll go through that process in more detail. But just to place us before I jump into it, and start with reflecting and emphasizing, what we are all aspiring to, as we are right in the midst or the middle of the 2030 agenda, in which these sustainable development goals, as the follow-up to the Millennium Development Goals, anchored us in our commitments and contributions to affirm actually the front and center role of communities. And this was really to highlight, how do we promote ownership? How do we redefine platforms and systems? And when I'm speaking about systems, we're talking about, public sector as well as community systems, and the accountability that we all have to elevate people as key actors in their own development. This was basically the impetus and the drive behind why the community engagement minimum standards and indicators were developed. It was really to recognize the significance that social determinants play in development, as well as the importance of community level action, and the leadership that communities actually can play, and ownership in all aspects of policy, research, and practice. Next slide, please. So just to define what were the principles that were at the heart of the development of this document, because actually it is a document, but there was a process to develop the document. The intention really, as also Kelly and Olivia have already mentioned, is to elevate the focus and accountability of community engagement, and to highlight that it is an intentional process. And it requires systemic approaches as well as investments and metrics. We need to be able to measure progress. So we really need to make sure that we can focus on community engagement outcomes beyond just the disease-specific and the service-related outcomes. So while we are aiming to address disease-specific outcomes as well as service-related outcomes, we really have to understand that community engagement is an outcome in and of itself. So having said that, usually community engagement is approached as a more instrumental approach. Olivia mentioned in the beginning saying that it is usually a means to an end, in which engagement or mobilization approaches are leveraged to accomplish goals or outcomes in health and education and nutrition or social welfare, to make sure that there is participation and empowerment happening. But so it can be that approach. But to say that community engagement is intentional and an outcome, that is the end in itself, right? That we ensure that empowerment is a process that continues to happen, that we continue to invest in local communities' capacities, continue to explore and plan and act together on issues that are priorities to the community. So if we're able to do that as partners, as UN, as global and regional and country level partners, and civil society and the multiple facets of civil society, NGOs and academia, among others, then the core principles that we aim to achieve is quality, recognizing community engagement as a process, as well as an outcome. Achieving accountability in meeting and setting expectations on the role and responsibility of all of us as different actors to demonstrate the value for community engagement. Harmonizing our approaches across organizations and contexts, and hence the need for having standards and indicators. And then optimizing our interventions. More isn't always better. Having so many partners in a community isn't always better. We should not be competing with each other. We want to make sure that we're creating an enabling environment that is supportive of the community and delivering then high quality and evidence-based community engagement. Next slide, please. Next slide. Okay, so the fundamental principles that I just spoke to that inform the quality standards were drawn from international frameworks. And this is just to mention a few of them. And of course, you will have the presentation to be able to reference this as well as the document. This is just to note that the standards were intended to complement the existing standards and the overall broader frameworks that are already existing in terms of development and humanitarian practice, to ensure that we are abiding and realizing a rights-based approach, equity, diversity principles, accessibility, considering local capacity and empowerment, and embedding that throughout all community engagement activities. Next slide, please. Next slide. Perfect. So just to really quickly say what this process entailed, because it was an 18-month process, and the discussions really were motivated and stimulated during the post the West Africa Ebola crisis that I think everybody remembers in 2014, 2015. And that also drove the need to community engagement at the forefront, not to consider it after an intervention or an emergency. Sorry, there's an echo. Okay, perfect, thank you. So just to say that from that moment on, there was a movement, I would say, amongst multiple organizations and stakeholders that work in the field of community engagement. And UNICEF was basically, a chair that said, okay, how can we organize this, coordinate this, and bring this all together and work together as partners? So we started with reaching out to multiple organizations that have presence. UNICEF itself, I'm sure many of you are aware, we are in more than 150 countries and work with civil society very much, as well as government and multiple stakeholders. So in the work that we did, the key collaborators that we also, just to mention a few, were organizations like MSF and the World Health Organization, the Centers for Disease Control, the European one, the US Center, donors like Wellcome Trust and USAID and Gates Foundation, civil society partners, Oxfam, Save the Children, World Vision, Core Group also was very much engaged, which is also another civil society platform, as well as universities like the London School, MIT, as well as government partners that we also engaged with. So between a desk review, as well as multiple consultations, even country level consultations, that was mainly how we arrived at developing this over an 18-month period. Next slide, please. Next slide. Okay, so the framework for the standards, and I put the link in the presentation so you can actually check out the document yourselves, and really hope that it will stimulate your interest, and please reach out to us for more. But also really reflecting on how do we utilize this tool and this document that really frames minimum standards. The standards are broken up into 4 parts. The core of it is really the first part, which are the core standards that should be driving the other areas that are mainly focused on application and practice. So part A presents 6 core standards, and the next 3 sections in part B, there are implementation standards, 4 implementation standards that are proposed. In part C, there are coordination and integration standards proposed. There are 3 of them. And in the last part, there are 3 standards in part D. Now, to mention the uniqueness of this, because as I mentioned, we went through extensive desk reviews and documents and reports and consultations. I truly say one of the unique things of this is in the review process of all of these documents and files, one of the things that really was a consensus was that we need to have indicators. And we need to drive standardization processes around indicators. So in this minimum standards and indicators guidance, we provide indicators proposed for national and level government use, as well as civil society and implementing partners. So I will be giving just a snippet about that, but I think that is what is truly unique about this. And when you engage with the document, you will find it interesting. The other two significant tools that we incorporated in this document, which is proposed to be a live document. So based on experiences and its implementation, we aim to also provide further tools and disseminate those. There are checklists that are incorporated in this first document. One is a project cycle checklist, and the second one is a funding institutions checklist. And I think, as Kelly had already mentioned, how do we ensure that this is incorporated within processes at all levels? So in driving the need and the focus on intentional community engagement, what do donors need to do to ensure that these processes actually are supported in a structured manner and that we can track that? So the project cycle and the funding checklists are there, available, adaptable, usable. There are many experiences from country teams that have taken it forward, as well as organizations, but unfortunately I don't have the time to share all of that, but we can definitely share that going forward. Next slide, please. So I'm just going to quickly be able to give an overview of the climax of the presentation, which is the standards themselves. This is a summary table of what the standards are. For each of those parts that I mentioned, you will find the standards actually stated. In the document itself, for each of these standards, there is a description of the standard, which provides a summary rationale for it. And that rationale can be, universally applied in different contexts and settings. The next part of the description within the document provides quality criteria. And what those aim to do are to provide, standard principles that detail minimum targets to achieve quality community engagement for that specific standard. And then the final thing in the description under each of one of these standards is that there are actions that are provided. And these actions provide advice for operationalization of the standard. So, these suggested standards, as I mentioned, could be included in multiple types of program and project implementation processes. Everywhere from proposal writing to budgeting, to even budget reviews, to developing M&E indicators, but more so the systems, because it's not just about, coming up with many indicators. It's about having actually just really core indicators that you are actually able to track and integrate within systems to raise the bar in terms of how do we measure community engagement and show the value add of it, and how do we generate the evidence to ensure that when we're saying community engagement is essential, we actually can talk about what operationally that means, and also what are some of those outcomes. So M&E is super critical, and so when we're thinking about how do we use these standards and indicators, it should be from the conceptualization process of our program actions. The audience, of course, that we intend, to use this is everyone from, our global networks to communities of practice to implementing partners, and that's why our focus in the next phases, as we're working with our multiple partners in countries mainly and at regional level, is to develop more operational tools on the use of this, and also documenting different types of contexts and uses of how the standards have actually been applied, and bringing that together so that we can also coordinate better, and really advocate for, health system strengthening that incorporates community engagement. And so it would be really amazing to see that happen, and malaria elimination initiatives to contribute to that, to how do we use that, and from that evidence that we do generate, bring that much more into the health system strengthening space. Next slide, please. So as I'm wrapping up, I will end with the main pitch that I actually said was so unique in the development of this minimum quality standards and indicators document, is the indicators that we propose. And it's not just, proposal from UNICEF. Again, as I mentioned, this was a consensus building process in which we wanted to ensure that we incorporate indicators to reinforce that community engagement needs to be intentional and systemic, so we must be able to measure it and to develop the systems that will enable us to measure it. So how do we quantify and qualify and measure these outcomes, and also propose and really emphasize the need for uniformity to measure the outcomes versus just, we have the common indicators of disease incidence and uptake of services and tracking those things, but what do we need to track in terms of community engagement at a quantitative level and qualitative level? What do we integrate within systems? So this was basically the drive behind and the motivation why we incorporated community engagement indicators within this document. And I just have a quick snapshot in the next 2 slides that share these common overall indicators that we've proposed. So next slide, please. This is one example just of the Part A core standards. When we're thinking about, the standard for participation, empowerment, and ownership, two-way communication, the 6 core standards. This is a sample indicator that have been proposed. And, of course, the uptake of indicators means that, it requires the development of how data collection will happen and what will be the methods and how to integrate it, who's going to be accountable for collecting that data, and more so, what is the data need behind that? Who will be using that indicator at the end of the day to track it? And the consensus is to, when we are identifying indicators, I always say less is more. If we're effective in tracking a few core indicators around community engagement and integrating that within systems. So it's not just us as an NGO or an intergovernmental partner or for academic research, but also government partners are using this to effectively make decisions. It will improve the quality of community engagement as well as services, as well as ensure that government will make the right investments also to further continue investing in communities. So the next slide, if we can go to the next slide, which is the last slide. This actually gives just an overview as well of some of the core standards that we also propose to be integrated in national and local government systems. That requires, of course, a lot of advocacy, but you will see a lot of similarity from what we propose at the civil society level and what can be collected at that by partners within civil society, but how it also relates to what can be integrated within national systems. Again, all of this to increase, the quality as well as the accountability of the different partners and their roles in ensuring that we can deliver quality community engagement. So thank you for that. I know that was a lot of information. I really hope that you will have the opportunity to delve into the document itself and share your experiences back, and also connect with UNICEF partners, hopefully in different countries, if you're not already working together, because we do very much work on malaria elimination also as UNICEF. And I will stop there and say thank you. Last slide.
Okay.
Thank you.
Thank you very much. This is wonderful. This is great. Thanks for the presentation. Very insightful. I believe we are all putting our questions in the chat box. So we'll continue with the presentation. Our next presenter is João Baptista Nelo. Baptista is a program coordinator of the Trans-Kenny Malaria Initiative project implemented by the Anglican Diocese of Angola and the Isdell Flowers Cross-Border Malaria Initiative. He is also a member of CS for Me Today. Today, he will be sharing experiences collaborating with communities to eliminate malaria in the Cubango province of Angola. Baptista, the floor is for you. Thank you very much.
Thank you very much, Cecilia, and I'll turn on my video for introduction. My name is João Baptista Nelo, and I work with the Anglican Diocese of Angola and the Isdell Flower Cross-Border Malaria Initiative. Today, I'll be talking to you about community engagement through Community Malaria Elimination Committee in Angola, Cubango. Next slide, please. Next slide, please.
Yes. Yes, Nelo, can you please speak a little bit louder, please? Thank you very much.
Sorry,
and I just want to remind everybody to send your question in the Q&A box. The previous speaker have started to respond to some of the questions. So thank you very much, Nelo. Thank you, Cecilia.
Okay, thank you. I don't know if my voice is now audible. Can you now hear me? Is it fine?
Yes, thank you very much. Thank you.
Very good. Thank you, Cecilia. So I've introduced myself on the previous slide. So the Isdell Cross-Border Malaria Initiative is committed to malaria elimination through community mobilization along the shared borders with Angola, Namibia, Zambia, and Zimbabwe. And we believe that malaria can only be eliminated if those living with the disease have the knowledge, have skills, and have resources to prevent and to treat the disease and to advocate for its elimination. Next slide, please. Next slide, please. Okay, to understand malaria, the context of malaria in Angola, it's important to know that malaria is the primary cause of death in Angola. And in Cubango, where we work from, if you have a clear look on the map, it's actually on the bottom right side, bordering with Namibia and Zambia. It has about 38% of prevalence in children under the age of 5. That is according to the DHS 2015-2016. Obviously, things have changed, have slightly changed, but still have a lot of malaria in the area. And we work from the borderline, and there are few government services in this area. And before COVID-19, people often crossed to Namibia to look for better health care. And the community in this area are isolated. So we are talking about 12 hours of drive from this area to the provincial capital. And historically, there have been few malaria activities happening in the area. Next slide, please. As I've mentioned on my previous slide, there have been historically few malaria activities happening in the area. So the community decided to organize themselves in a group in order to keep the key malaria activity running. And that's where the COSEMA comes in. The COSEMAs are community-owned committees. And through the COSEMA, all the Anglican Diocese and the Isdell Flower malaria activities are conducted under their leadership. And COSEMA stands for Community Malaria Elimination Committee. For those that speak Portuguese, it's a Comitê Comunitário para a Eliminação da Malaria. And through COSEMA, leadership is transferred to the hand of the community in order for them to keep running community activity even without external intervention. Next slide, please. So now that I've brought you the word COSEMA, it's also important that you understand what a COSEMA is and what it does. A COSEMA is a community-owned group whose members are chosen from the community, and the selection of its member that is not related to any formal education, but it aims for a well-balanced group of 8 to 12 members. And this includes village headmen or chiefs, religious leaders, and just to emphasize here, religious leaders are not here to take advantage to mobilize people to their churches, but they are here because they're people that are trusted in the community. They are also teachers and other influential individuals, like example of Mr. Mateus Mandume, who is a man who sells phone credit on the street, and he was chosen to be part of this COSEMA because he interacts with everyone. He is known by everyone and he is respected in his community. The COSEMA capacity building should happen at the invitation of the community, and the COSEMA should not be affiliated to any political party to avoid conflict. Plus, the COSEMA determine their own procedures and operation, so they decide which day of the month to meet, where to meet, what to discuss, and how to address some issues within their communities. Next slide, please. So what do COSEMA do? COSEMA engage malaria elimination activities. They identify and they address every barrier to effective implementation. They support, they select, they manage community malaria volunteers, and they also advocate for service desired by the community. Plus, they serve as a bridge between community and the government, and they act as a community platform to address other issues affecting the community as they arise. Next slide. So you might be wondering, I've been mentioning COSEMA since the beginning, and you might be asking yourself, where do we actually come in and what do we do? So the Anglican Diocese of Angola and the Isdell Flower, as CSO, interact with the COSEMA by providing training sessions for the volunteers that are selected by the COSEMA, support during their meetings to assure that the minutes that are taken are shared with every partner that's interested, and guidance structure for the new COSEMA. We also collaborate in a way that the trained volunteers have an oversight from our field officers on the ground, and we also help to link the COSEMA to the government sector to amplify community desire and to align activities or their activities with National Malaria Control Program's national strategy. And our goal of working with the COSEMA is to assure that the community takes leadership role in order for them to gain skills and capacity to continue running malaria elimination activity even if we cease to exist. Next slide. So I'll be now sharing with you some practical examples on how COSEMA deal with a situation in the ground. And before I go to the example, it's important we understand that COSEMA members are part of the community and they are selected by the community to represent them within the COSEMA. But then they further work to assure that every community member through community mobilization takes part in every malaria activity happening. And my first example will be related to net use. In 2018, after the mass net distribution, a big number of people was using net for fishing. So the COSEMA during their meeting have decided whoever was found using a net, the net will be confiscated and this person will be taken to the chief's house for further education, and a volunteer was assigned to help hang the net and to follow the net hang during their regular visits to the households. Next slide, please. In addition to community mobilization, the COSEMA-led community engagement strategy aims to assure that every household in the community receives education and other malaria services. And this is done through community malaria volunteers who are selected from who are members of the community, selected by the COSEMA and managed by the COSEMA. And the community mapping and planning aims to assure that every household is divided into a zone to assign volunteers and to assign volunteers who visits the households in a regular base. And the education and the mobilization in churches and schools also happen through lectures that are conducted by the COSEMA and the volunteers in the community. Next slide. Next slide, please. Another example is on the sustainability of the COSEMA and how they act as a platform to address the issues in the community. In 2019, the southern part of Angola was affected by drought, and the crops that were grown by the community dried out. So most of the community members, especially the young ones, stronger ones, were leaving to Namibia to seek for better living conditions. And most of our volunteers actually part of this group, the young ones. So the COSEMA and the volunteers decided to sit for a meeting, and they came to the conclusion that whoever was leaving to Namibia would select someone from the community that will be trained by our field officer and monitored by the COSEMA to keep the malaria activity running until the volunteer returns and takes over his activity. So during this period where people were fighting, were actually trying to prioritize between survival and malaria intervention, the community kept malaria activity running because they understood the importance and they had ownership, and they have ownership of the program. Another example on how this platform does not only address malaria but address other issues. Last year during the vaccination campaign, some households were left out in Kalai. So the COSEMA wrote down their names into a list, and then I've prepared them and called the vaccination team to return to the area and to vaccine the other kids that were left out. Next slide, please. So we have been working with COSEMA for quite a long time, and during this period we've learned a lot of lessons, and here are some of our key takeaways. It is important that the community understands the importance of the COSEMA and should want the COSEMA before it is created in the community. And then it's also necessary that the COSEMA gets linked to local authority to increase sustainability. It's also good to have multiple villages in the COSEMA to allow exchange of experience and better problem solving. Plus, the COSEMA should cover relatively small areas so that its members don't walk far for their meeting. Plus, the COSEMA should be active, should be strong, and should be trusted before intervention happens. And definitely, their meetings should happen regularly. Next slide. So coming to what I've come to the end of my presentation, but it's here more than clear that the only way we can achieve malaria elimination is by putting the community into the driver's seat. This is the end of my presentation, and thank you very much.
Thank you very much, Baptista. Shall we clap for Baptista? Well done, very good presentation, giving a lot of information on your work with community groups and civil society, very insightful. I think Olivia would like to share something with us before we continue. Olivia.
Yes, thank you very much. Thank you, Nelo, and thank you, Cecilia. So next we will have because our colleague from Thailand have a special video that we're going to play after Ayo's presentation. So thank you very much.
Okay, thank you, Olivia. So our final presenter will be Ayo Imponi from the Civil Society in Malaria Control, Immunization and Nutrition, ACOMIN in Nigeria. Ayo is the national coordinator of ACOMIN, a member of Nigeria's country coordinating mechanism of the Global Fund and steering committee member of CS4Me. You will be sharing insight from ACOMIN's experience with community-based monitoring. Ayo, the floor is for you. Thank you very much.
Thank you very much. Let me start by saying thank you to the organizers and colleagues on this important webinar. I really appreciate all the efforts you have put in. Thank you very much. And I am presenting this on the behalf of 195 CBOs, community-based organizations, and 195 local communities that we've worked in over the past 2 years. The CBOs are actually the ones who made this happen with their community-based volunteers. 780 in all, staff and volunteers, persons who have worked. So say thank you to them. Some of them are on the call. Thank you. Now, let's go forward. Now, I will start by explaining what we understand by community-based monitoring. It refers to a set of activities through which end users, that is communities and community-based organizations, monitor the quality, the availability and suitability of services. It focuses on the client's satisfaction and perceptions of services rendered and promotes the perspectives, participation, and ownership of the communities. So when you use the term community-based monitoring or community-led monitoring, the emphasis, the focus is on the communities. The communities are the ones who determine the quality, the availability, and the suitability of services that they are receiving. The emphasis is on the client, not on the service provider. Wikipedia describes it as a form of public oversight driven by local information needs and community values to increase the accountability and quality of social services such as health, development aid, or the management of natural resources. Again, the emphasis is on the community and community perception of the services being received. According to Global Fund, community-based monitoring is a process by which service users or local communities gather and use information on service promotion or information on local conditions impacting on service provision in order to improve the responsiveness, equity, and quality of service and hold service providers to account. Again, the emphasis is on the service users, on the local communities. Let's go forward. Next. So, community-based monitoring is not the process of delivering services to communities. It is not monitoring and evaluation, which we are all used to. It is not quality control, data quality assurance, or service provider supervision, which we are all conversant with. Next. Next. Okay. Rather, community-based monitoring is a bottoms-up approach. It is different from the top-down approach of monitoring and evaluation, where the service providers, the donors come from federal or state levels down to the communities to determine the achievement on macro level targets and financial accountability. With the MIE approach, the implementers or the donors are not able to deal with local realities and individual needs. But from the perspective of the community-based monitoring, it starts from the community, it starts from the client, it starts from the end users. So what we are looking at is what satisfies the receivers on quality, suitability, and utilization of services and commodities based on local realities. It ensures that the voices of the end users or the clients are heard and important in the process. It strengthens community participation and ownership, extremely important. Community ownership of services delivered, and it enables community and local contributions in investments in healthcare. And one thing is that community-based monitoring is closely linked with advocacy. When we carry out community-based monitoring, it's not done for its own sake. It's not just for the sake of reporting to donors or to Global Fund or any other group of people what is working well and what is not working well. It actually now devolves into solving real-time problems. So when evidences and observations are gathered, it results in targeted advocacy to bring remediation to issues. And there are two components to community-based monitoring. One is accountability, social audit. The other is advocacy. Next slide. Now let's quickly make this clear. In malaria, we define community a little differently than in HIV. Community in HIV will refer to community of care, care receivers, people living with HIV, key populations, people who inject drugs, MSM, those form communities. In malaria, particularly in the work we are doing, community is more of geographical locations, people who live in contiguous environments. And then that word environment is extremely important to malaria because the environment that we live in is what provides opportunity for the reproduction of the malaria parasites. So living within a contiguous environment is a community, and communities have cultural structures. They have accountability systems by which people live. That has to be factored into community-led monitoring. Now, talking about accountability, it is an assurance that an individual and organization will be evaluated on their performance or behavior related to something for which they are responsible. Corporate accountability involves being answerable for the actions and results of the organization to the stakeholders of the organization. Now, accountability is important in evaluating the effectiveness of public officials, bodies, interventions, NGOs, donors, and in ensuring that they are performing to their full potential, providing value for money. Now, accountability involves two stages. One is answerability, to be able to answer for the decisions that you make. The other aspect of accountability is enforcement, which means that the institution responsible for accountability can sanction the offending party or remedy the contravening behavior. As civil society, we do not have the power to sanction or to punish any public official or implementer that is not living up to expectations, or even communities, but we can remedy the situation through our advocacy actions. Next slide. Next. Taken and issues highlighted to change what is into what should be, considering that what should be is a more decent and more just society. So with advocacy, this is where we actually bring change into the issues that we want to see happen. And advocacy makes our voice as civil society very strong. We identify key decision makers. We engage with them, because these are the people who can actually bring the change. They are the ones who react to us. And when we bring our issues to the forefront of the public agenda, we're able to shape their agenda. One of the things that we realize in Nigeria, which is true for every other country, is we tell ourselves that no government official upfront goes to government or to the public space or to office because of our priorities. They have their own priorities. Our job is to engage with them and ensure that the priorities of the communities that we represent becomes their own priorities. And when we persuade them to buy into our priorities in malaria, then we are changing the narrative, we are changing the agenda and making things happen. Next slide. Next slide. Now, although community-based monitoring is community-led, it is structured and systematic. What we have done in Nigeria is to set up observatories or teams. The community observatories are tagged community accountability teams. Each team is equipped with a set of tools, both technological-driven tools and paper-driven tools, and each team works within a geographic area, targeting relevant sets of stakeholders, service providers, service recipients, government and healthcare providers. Now, in Nigeria, we have 4 focal areas that our teams are focusing on. One is value for money, ensuring that the funds that are put in by local funds and by the governments of Nigeria at the different levels are actually achieving the purposes for which the funds are put. Number 2 is commodity utilization, by which we engage with the communities to ensure that the communities actually utilize the commodities. One very important thing to us is for the communities to use the nets for sleeping inside. In many cases, communities will use the nets for farming or they use the net for clothing. If that is done, then there's no work done. Everything we are doing, we achieve no effect. Another area is availability of human resources. The governments provide and partners provide the primary healthcare centers, but the government needs to put in the human resources, the staff. So we engage with the local government to ensure that the primary healthcare centers, where services are delivered to most Nigerians, are adequately staffed. Then the last area is budgetary appropriations and domestic resources, so that we are not just depending on donors. Our state and local governments are also putting in money and resources in health. Next area. Next slide. Now, let's jump over this. Let's go to the next slide. I've spoken to issues here. Next slide. Now, what we have seen happen is that since we started implementing this, we have seen increased budgetary allocations for malaria by state governments and local governments, because the communities have now been empowered to ask questions, they have been empowered to advocate. Like we said, we have accountability teams. Each of the teams is made up of a representative of the World Health Development Committee, a representative of the traditional leadership structure, and a representative of the CBO. And these teams work under a local community-based organization. So with the empowerment that they are able to engage in a fundamental way with the state and local governments. And this has really worked very significantly. We have also seen that with the activities of the community teams, the communities themselves are contributing to their own health outcomes. We tried to change the paradigm and the narratives around health in Nigeria, in those areas where we work. Rather than waiting for government or global fund, we challenge the communities to take ownership. And we have seen that when the communities begin to engage government, then they ask themselves the question, what are we going to do to ensure that our wives, our daughters, our sons, ourselves, that we have the care that we need? So we have seen a great improvement in community contribution. We now have more than 8 primary health care centers built by the communities. We have more than 30 of primary health community care centers that have been totally renovated by communities. We have boreholes for water that are being dug by communities. And then we are having communities actually providing resources to hire staff. Why? Because they now have a sense of ownership. And what has happened is because the communities are engaged, because the communities are active, the politicians dare not offend the communities. So that is one of the reasons why the governments, state and local government, are also putting their resources because the people are awake. Now, we have improved government participation and commitment at local government level. And this has led to improved collaboration with community members. We have in a situation where, for the first time in many of our local governments, particularly those areas that are hard to reach and the areas that where we have security issues, the government and the communities are talking to each other for the first time on areas of health. And we have these robust conversations ongoing. And of course, we have improved linkages with sub-recipients and relevant stakeholders at state and local government levels. This has improved government commitment, as well as service provision and uptake at the PHCs as a result of promptly attending to issues identified affecting the effectiveness of malaria interventions. So when the communities and the civil society get engaged in a collaborative way, in an area of having an ongoing discussion and advocacy, we find out that there is improved commitment and participation across board with both the sub-recipients for Global Fund, the principal recipient, the government, the communities, and we are now seeing, we saw this massive uptake of services and then provision of commodities, renovation of the facilities, and improved health outcomes. Last slide. Last slide. Thank you very much. I stop here.
Great. Thank you very much, Ayo. You've really given us a lot of information on the work that you do, community monitoring, civil society, community involvement. This is wonderful. Thanks a lot. We have a number of questions now, and I would like to give the questions, and then I'll read the questions, and then the presenters will please kindly respond to them. What I'll do is Olivia will be taking the first question, and then I'll continue. So the first question is to Rania. Is adaptability and localization related to contextual and joint formulation of solutions with the community? Can you share an experience on this? Rania. And this is from Andrew.
Thank you so much, Cecilia. Yes, I saw the question and I was about to respond, but then I was listening to the presentation. So apologies for that, Andrew. Absolutely. I mean, let's just think for 1 second, you know, in the context of COVID-19 that we're experiencing right now, globally, right? You know, if we're thinking about adaptability and localization, this is exactly what has had to happen. You know, right now, even during the response, we're working in, you know, 100, I think we coordinate with 7 regional offices, and we're working with more than 50 plus international development partners that are linked with NGO and civil society partners in all the countries that we're working on. One of the things that, you know, we can talk about is, you know,
much.
in I can put more details, Cecilia, in the message, in the chat box, in the Q&A box about the risk communication community engagement work that we're working on. So I'll do that.
Thank you very much, Rania. Again, Andrew is asking a question, and this is to Baptista. How is the GOSEMA group different from the Community Health Committee and where it is present? Baptista.
Thank you. I've answered that on the question and answer, but I'll say it again here. Actually, in all the areas we work from, there are no community health committees. So it's the COSEMA acting. So the COSEMA takes the role. That's why the community came up with the idea of organizing themselves into the COSEMA, which is actually a community committee for malaria elimination, but which deals with other issues apart from malaria. I don't know if I've answered the question.
Andrew, I hope you've been answered. If you need more question or maybe more clarification, you can contact through CS for me. Another question is to Baptista again. This is from Samuel Yao Ajimabedu. Is asking, please, I would like to kindly know from you which of the malaria prevention and control methods are COSEMA advocating for or promoting in the communities?
Thank you. As I've mentioned during my presentation, COSEMA works with a network of volunteers who do house-to-house visits. And during their visits, they teach the community from their houses on correct net use. They teach them on the importance of IRS and then the early testing and treating positive cases. So they actually look at all malaria prevention methods.
Yes. Cecilia, can you hear us? Yes. Oh, thank you very much. We will continue with question and answer in the Q&A, box. So please continue to write your questions there, and the speakers will answer live there. So next we're going to go. We're going to go to Thailand for Pratin's presentations, which is on a form of a video. So we're going to play the video of Pratin's presentation, and if you have questions for him, please write them in the Q&A box so he will make sure to answer. Thank you very much. So we'll play the Pratin's video now.
Muslim Association of Thailand, or YMAT for short, in this webinar. Okay. Yala is situated in the southernmost part of Thailand, close to Malaysia. Majority of population are of Muslim culture and heritage. The area has a lot of forests and mountains that serve as good breeding site for malaria vector.
Okay.
The warm is good for rubber tree plantation, but tapping the rubber sap before dawn does expose the resident to mosquito bites. However, with collaboration among many malaria partners, we saw a significant reduction in malaria cases during the past 3 years. YMAT has been working in Yala province for nearly 20 years, involving health and livelihood support, and started working in malaria since 2018, being a sub-recipient under Global Fund Right to E grant, and is continuing under the Right to E grant until 2023. So everyone. At the start of the Right to Eat project in 2018, YMAT conducted an assessment and some surveys in order to understand the situation. It was found that the malaria service workers who are mostly the government workers are very busy at their health facility because of high burden. The staff were very busy and fully occupied at their facilities. And getting into malaria elimination, we have adopted the 137 strategy that require case-based response, which means increased activity, active case detection, IRS spraying, and malaria risk communication in the community, which is a lot of more work to be done. And also majority of malaria cases are vivax that require 14-day treatment. On the affected population side, it just found that people work at night time, often did not sleep under the mosquito net or the long-lasting insecticide-treated net. Or some did not see the connection between mosquito bites and fever. Some waited many days after fever to get malaria test. And some patients, after feeling a bit better, few days after start taking the medicine, they stop the medicine. And some did not like IRS being sprayed in their household. So there were a number of challenges, but these were due to inadequate community education. Next, please. The experience of YMAT in working on malaria in Yala is that we have to combine the infectious disease control principle together with the community engagement strategies. In disease control, we usually say that we need to know our epidemic and know our response. In Yala, malaria affected all age group, young and old, in the community. So there are a range of interventions that need to be done. The point that I like to emphasize here is that the knowledge about malaria and what needs to be done cannot stay at the level of health worker. It has to be communicated to the community members in the way that they can understand to lead to behavior change and local ownership, so that we can achieve sustainable malaria elimination in the long term. In working with the community, the key principle is that you need to know the community well in order to work well with them. You need to know the structure, the strength, the resources, the actors and dynamics among different groups in the community. In other words, you have to know who is who. Then from that, you build on and enhance the roles of those that can support the cause of malaria. In the case of Yala, YMAT has identified community leadership that has been called the 4 pillars. Okay. Next, please. Working in malaria, YMAT see building strong community as very important objective. Strong community means it has to be the community with the knowledge and capacity to take action against malaria, because CSO project will be implemented only in short period of time. But once the community can take the action against malaria by themselves, the work can continue even after the CSO has left the place. So this is very important objective of YMAT. in building community knowledge and capacity. The key strategy of YMAT here is working at 2 levels of communities at the leadership and also at committee level with the operational team. I would like Mr. Rawsidee to help explain the approach, why this is important.
ให้ผมพูดใช่ไหม
ใช่พูดภาษาไทย
ก็ในส่วนสำคัญที่อาจารย์ได้กล่าวถึงเมื่อกี้ก็คือส่วนที่ผู้นำ4 เสาหลักในพื้นที่ชายแดนใต้ผู้นำ4 เสาหลักเป็นบุคคลที่มีความสำคัญต่อการเปลี่ยนแปลงในชุมชนเพราะฉะนั้นแมทเลยจับยุทธศาสตร์ที่สำคัญก็คือการกับผู้นำเพื่อให้ผู้นำ4 หลักนี้เป็นผู้สนับสนุนการดำเนินงานในชุมชนซึ่งในชุมชนเนี่ยทาง YMAT ได้สร้างนักสื่อสารความเสี่ยงมาลาเรียขึ้นมาเป็นคนดำเนินการในเชิงพื้นที่เพราะฉะนั้นการดำเนินงานจะบรรลุความสำเร็จได้นี่ต้องอาศัยบทบาทสำคัญของนักสื่อสารซึ่งบทบาทสำคัญของนักสื่อสารแต่นักสื่อสารจะประสบความสำเร็จไม่ได้ถ้าเขาไม่ได้รับความร่วมมือจากผู้นำ4 เสาหลักเพราะฉะนั้นการทำงานกับผู้นำ4 เสาหลักเราจึงเน้นหนักอยู่ที่3 เรื่องที่1ก็คือทำให้ผู้นำมีความรู้มีความเข้าใจในเรื่องของโรคมาลาเรียประเด็นที่2ก็คือเข้าใจเรื่องสถานการณ์ของการแพร่ระบาดประเด็นที่3ก็คือบทบาทของผู้นำว่าภายใต้สถานการณ์การแพร่ระบาดผู้นำควรจะต้องมีบทบาทอย่างไรแล้วก็จะมาช่วยเสริมทีมนักสื่อสารอย่างไรอันนี้ถือว่าเป็นความจำเป็นที่ทาง YMAT ได้ใช้ผู้นำ4 เสาหลักเป็นผู้นำการเปลี่ยนแปลงหรือเป็นผู้สนับสนุนให้เกิดการเปลี่ยนแปลงในเชิงพื้นที่ครับผมเชิญอาจารย์แปลเลยครับ
Okay. The committee leadership that we call the 4 pillars are very important for change in the community. Their roles are to support the operational team. YMAT has built the capacity of malaria risk community communicators who work in the community. However, the risk communicator alone or the operation team alone in the community will not succeed if they don't have the support and blessing of the committee leadership, which are the 4 pillars. So in working with the 4 pillars, what YMAT has done is, first, you have to empower the 4 pillars with malaria knowledge so that they understand the malaria situation in their own community, and then the roles of committee leadership as to what they have to do in order to support the operational level done by risk community, community health volunteer, and other activities that conducted by malaria clinic staff, for example, the spraying of insecticide and so on. So these 2 levels support, needs the operational level need the support from the 4 pillars with the leadership in order to succeed. So these are the example of the activities that show YMAT use malaria information to meet and work with the committee leadership so that they can understand the situation and develop malaria plan for the community. Yeah, this helps them to understand where they are right now, where they want to go, what they want to be, and as such, one of the key resources in the community is the local administrative organization that have the local health fund that can support to address health problem in the community. So this has been a key financial resource for the community to develop malaria intervention activity that needed to be done, locally. Next, please. Yeah, we talk about malaria risk communicator. This is a very important group of actors. They have been developed from village health volunteer, the malaria post, but then their roles have been enhanced in order to work more at community level to provide malaria education and support and complement the role of health facility staff. A lot of them are young women. I have to say that, yeah, very impressive, very active, yeah, hardworking. Okay, next please. Yeah, this slide show how these 4 pillars, yeah, see at the middle here, the local government authority, village chief, sub-district chief, and then local administrative organization that have funding support, and then the imam or religious leaders. The religious leaders are very important. For example, if you go to villages in Yala, at the mosque have loudspeaker to speak to the community. So this has been used as very important tools to communicate religious and health and malaria messages to community members. So the role of imam or religious leaders has been very important. Yeah, and the last pillar is the community volunteers. Many of them are women groups and so on. So they're very good in communicating malaria messages among fellow community members and so on. So all this work together to support different range of measures from vector control for education, patient follow-up to make sure that patient take the whole of medicine for the 14 days and do not stop so that the parasite can be clear. Next, please. This picture shows some activity of health education conducted by malaria risk educator at the community level. During the past year, this is the target of the Right to E activity. The target was over 2,200, but the result exceeded the target set. In the content of the activity, they will discuss the malaria situation, how malaria transmit, and then what they can do is making mosquito repellent by themselves, and then learn about cycle of malaria transmission. Yeah, even if you don't have symptom, but if you have malaria parasite in your body, you can transmit it when a mosquito bite you and bite your neighbors or your relatives in the same household. Yeah, so these are the basics of the community health education in malaria. Next, please. Pupils. As I mentioned earlier, malaria in Yala affects everyone, young and old. So when malaria affects young children, it means it is indigenous malaria because children do not venture far away from home. And that's why doing malaria education with school children so that they can know about malaria and prevent themselves from mosquito bites and use all the preventive measures is very important in order to reduce the malaria cases in Yala. And this has been done very successfully. Yes. As, so this last slide is just the recap of what Mr. Rawsidee has said before, that the good result and success have been due to the support and collaboration of the leadership that provide a lot of support to the operation team at community level. The leadership help reinforce, enhance, and that's how the success come about. Yeah, you have to work at 2 levels, the leadership and then operational level, and that led to quite remarkable reduction of malaria cases in Yala province during the past 3 years.
Thank you very much. Thank you. So thank you very much, Pratin, for the video. Pratin is here with us online, and Pratin and Rawsidee are online. So if you have questions for them, please write to the chat. We are actually almost at the end of our webinar. I know a lot of you wanted to take the floor to ask questions. We have received a lot of questions in the chat. So Ayo, I will just quickly, we just take 5 minutes to go over some of the questions, and I see our Job from Senegal who wants to say something, and we also saw all of your messages. So thank you very much for all this engagement that you have. And we look forward to continue to work with you also. Just quickly, so Ayo, there was a question in French for you. Pouvez-vous nous partager votre expérience dans la surveillance et l'exigence de la qualité des services offerts aux populations? So can you share your experience in the monitoring of the quality of services that are given to the population? So how do you monitor the necessity of the quality of those malaria services? Not just the services, but the quality of the service. So Ayo, if you can please note that questions, and you can answer that. And so we also have El Haj who asks how to meet, comment rentrer en contact avec les partenaires qui appuient la lutte contre le paludisme. Yes, so El Haj asks how to get in touch with partners who support the malaria fight. So, I don't know, je ne sais pas, El Haj, si vous parlez des partenaires de ce webinaire ou des partenaires en général. So El Haj, we will answer you directly on how to do that, but you have a website, email, contact address of most of the partners. So Ayo, there's also another question for you. Please, at what time do you seek for policy change, and at what time do you challenge community to take responsibility of their own health structures? Please, can you share how the communities are able to raise their own funds without the support of the government? So Ayo, please, you have the floor. If you can answer those two questions. Thank you very much.
Thank you very much. To monitor the quality of services, we have developed tools which the community volunteers have. Those two, there are 3 sets of tools. One is the client satisfaction, which will talk to the client and ask them questions on the quality and their satisfaction with the services received. Then we have another set of tools by which we interrogate the healthcare providers. That is a key informant tool. Then we have a third set, which we use during the focus group discussion, where we talk to the communities as a whole. So we triangulate information between the healthcare providers, the clients and the service receivers, and the communities. So within those 3, which we go through those elaborate set of questions and tools, we're able to elicit the 4 set of information. Then we now engage and dive deeper to find out actually what's going on. So that is how, and the tools have taken into consideration all the services that should be provided and the quality that should be. So the volunteers who are trained in the use of those tools then ask the relevant questions. How do we affect policy? The issues that we now identify at the community level by the community teams then go up to the state advocacy team. So it's not every team that is trying to affect policy. We aggregate the issues and take them as common issues and engage with the state and local governments based on the collection of the issues that are identified by all the teams working. So we engage with the state government, we engage with the local government, and also because ACOMIN sits on the CCM, second vice chair of the CCM, and also because we participate in all the committees with the National Malaria Program. We use those opportunities to actually write in the policies that are relevant to the communities that we serve. When it comes to community and civil society, we actually write in those policies and the guidelines. So we participate at those high levels based on the information that we have from the communities. Then at what point do we challenge the communities? When we enter a community, our first point of call is the community leadership. In Nigeria, we have the traditional leaderships, kings, emirs, sultans, district heads. Those are our first point of call. And then we have discussions with them, and the focus group discussion is facilitated by those. So when we finish our work at the facilities, at the communities, we come back to the traditional leadership. And that's where we engage with them with what we have found out. And we discuss with them what they can do and what and how they can do it and the impact. So what we find out is with the understanding we give them, they are willing to work. And how do they raise money? The communities. Within the communities are local philanthropists, their own sons, their daughters who are working in Abuja, who have money. Usually they will send for them to say, we have something to do in our community, please come back home for our help. So we have seen situations where all those, the sons and daughters of the communities, when they are called upon by the community head, they respond. Because here, our people are very tribalistic. Everybody, whether you are living in Lagos, you are working in Abuja, everybody still relates to their native village. So we work with that, and the local native leaderships call upon those people. And in addition to that, they also task themselves to say different age groups, different organizations, the church, the mosque, all of these people will also contribute as the first point. So it is when they have contributed, then they engage with the government and local government to say, this is what we have done. Now we want you to build upon that, and it has worked. I hope I've answered the questions.
Yes, thank you so much. Thank you very much, Ayo. So Nelo, I hope you can hear me very well. There's a question from you from Niger, from the National Malaria Control Program Director of Niger. So welcome, Dr. Jaku. So Nelo, your presentation is, have you evaluated the project and what is the prevalence of malaria after the evaluation? So Nelo, have you, in Angola, have you evaluated the project? And what is the malaria prevalence after the evaluation? And we had another question for you. Yes, just 1 second. Okay. So the other question also was from Senegal. How do you monitor the net usage in the communities? Dans la question de El Hadj from Senegal, how do you monitor net usage in your communities? And lastly, Nelo, still questions for you. So great lesson from Angola is very inspiring as well. Are the community health facility workers part of the COSIMA? How do you strengthen the relationship between COSIMA and the health facility? So very good question. So Nelo, please, you have the floor. Thank you. So Nelo, if you can hear us,
okay.
You can
sorry, I was muted. Sorry.
Okay, thank you.
Thank you, and thank you, Dr. Jaco, for your question. On my presentation, on the second slide, I've shown you data from 2015, 2016, and that is what is available so far. So that's why I've actually brought that data into my presentation. But definitely, studies are being conducted, and we're still waiting until it's provided to share with everyone. So, and the second question is actually on how do we evaluate net usage. First of all, I would like to say we don't cover the whole province. We're actually working along the borderline. And we have been conducting CAP survey we conduct CAP survey every year. And we've conducted CAP survey last year as well, where we also measure the number of nets being used relative to the number of nets that were distributed. And we have this information available, and we will definitely, as soon as the treatment of this information is finished, it's going to be shared with all of the partners. So we conduct CAP survey every year to monitor the net usage in the communities where we are working from. And sorry, I did not get the last question. I lost you in between for the last question. I don't know if you can repeat me on the last question, please.
Yes, the last question was about community health workers. If community health workers are part of COSIMA, and how do you facilitate the relationship between COSIMA and the health facility?
Thank you. To start, it's important we know that in most of our villages where we work from, there are no health units. But in others where there are health units, the health worker normally is invited to the meeting, the COSIMA meeting, and actually works in line with the volunteers as well, because every case that is detected from during the house-to-house visit, in case there's someone with signs of sign or symptoms of malaria, is actually taken to the health unit for testing and then treating. So they work directly in partnership, the COSIMA and the health unit.
Thank you very much. Thank you very much. So another question for Pratin. So Pratin has a difficult internet connection today. So Pratin, I don't know if you are able to speak, to try, but there was a question for you about, please, you center a lot of malaria prevention at the community level relating to your training. Kindly touch on how you undertake any malaria testing at the community level. So not only malaria prevention, but malaria testing. So Pratin, if you are able to try to speak, you can take the floor, or you can write the response on the Q&A section. So just, yes. Okay.
In Thailand, malaria testing at community level are being done both by RDT, the rapid test, and also by slides. Both methods are being used. Yeah. Is that the answer to the question?
Yes. So So also how you touch base on testing. Yes. So let me see. There's no more questions. So just a lot of comments. And so there was a general question for all speakers around how do you ensure that communities, organizations have a relationship with the government or the National Malaria Control Program, knowing that usually they are far away from the government officials, they work on specific projects, and how do you ensure that they build a relationship with the National Malaria Control Programs or the government official? So Pratin, maybe you want to tell us how this is done, maybe in Thailand? How to link communities engagement and work with government official and the Ministry of Health?
It's both through the Global Fund process. The CSO like YMAT is a sub-recipient to the principal recipient. The principal recipient in this case is the Department of the Disease Control. However, at provincial level, YMAT, which is the CSO, work with the government vector-borne disease control center and unit, both at the provincial level and at district level. So, and also the village health volunteer or malaria risk communicator, they have multiple roles. And one of the role is working closely with the health promotion hospital, which is within the government system, So they are naturally already connected with the government system. Yeah. However, from the national level, they can see that the reduction of malaria in the province is being monitored, the performance, the 137 performance, the malaria dot, and so on. So they and the government level know who is working at the ground level. Yeah, which CSO is working in this particular province and the approach, the activity that being done. So the work at the ground level are working closely between the government side, government worker, CSO, and the community, working very closely at the community level. Yeah, and because we have very good malaria online system, so the performance and so on can monitor very easily from all level, at national level downwards to the community as well.
Thank you very much. Thank you, Pratin. So last questions. There are so many questions. We won't be able to answer all of them today. We apologize, but our speakers have started to answer all some of the questions in the Q&A box. For the remaining questions that you still have, please email it to us. You will all receive at the end all the presentation, the email of the speakers, the video of the webinar, and you see the email, so you can email us all of your remaining questions. So last question is from Jean-Pierre in French, and any of the speaker can actually respond to that question. So Jean-Pierre asks quelques méthodes et stratégies à implémenter pour une bonne adhésion communautaire dans la lutte contre le paludisme dans un contexte d'insécurité où les communautaires sont moins préoccupés par les problèmes de santé. So Jean-Pierre is asking what are some of the strategies to implement to strengthen community engagement in malaria in an area of conflict. So in the area of conflict, what are some of the strategies to ensure still community engagement on malaria? I don't know, Ayo, if you want to take a step at it, since you've done the work in some of the states with IGPs and refugees in Nigeria, or anybody else, or Rania or others, if you want to try to respond. So to how does all of this apply in the area of conflict? Thank you. So whoever wants to try to respond, thank you.
So, continue.
Yes, go ahead, Ayo.
I was just going to say, I didn't hear the whole of the question. Internet fluctuated.
Yes, thank you. So the question was about how do you continue to ensure community engagement? What are the strategies you use in areas of conflict? So areas of conflict and insecurity, what are the strategies you use in those areas? Okay, thank you. What we have done in the last phase is actually engaging NGOs and community volunteers from within those areas. It has been challenging, but people who live, who understand the local context, who understand the local terrain, are more able to move around and impact their people than when people come from outside. So that's the beauty of the community-led monitoring approach, because it is the community that's on the driver's seat. Then we have areas that host internally displaced persons, IDP camps in Nigeria. We worked with some of those, but in this new phase, we are giving priority attention to those because they are traditionally underserved. And so we will be recruiting more of volunteers from within the communities that are underserved, the communities that have security challenges, and both refugees and internally displaced persons. And from lessons learned in the previous phase, we are applying those to this new phase. Thank you. Thank you. Thank you very much, Ayo. And thank you, everybody. We are at the end of our webinar. And we would like to thank very much all of our speakers. So Ayo, a CS for me steering committee member from ACOMIN in Nigeria. So thank you very much, Ayo, for your time as usual. Thank you to Cecilia from Ghana, from Hope for Future Generation, which is an organization also member of CS for me and very active on malaria and on the CCM Ghana. Thank you very much, Cecilia. And we also like to thank Rania from UNICEF for sharing those standards that we hope that everybody will make sure to read and contextualize in their own context. Thank you, Rania. And thank you, Pratin and Rawsidee from Thailand. Your experience was very, very interesting and is going to actually inspire a lot of programs around the world. So thank you very much for your experience. Also, Nelo, thank you for sharing that experience of concrete community engagement models and how they work to ensure that malaria programs continue to be effective. So we really appreciate that experience as well. And we say hello also to the Portuguese communities who joined this webinar. And thank you very much to Kelly as well from the University of San Francisco sharing the report, and the GC Flowers Foundation and all the staff, and also Alice that you don't see here, but who worked with us to put together this webinar. So thank you very much. And we thank our editors. So we know it was long, but thank you very much for staying with us. And so we had French, English, and Portuguese today, and thank you for your patience. One thing we learned in the year of COVID-19 last year was how to be very patient with technology. So thank you very much. We know that we have there's internet issues sometimes. There's a bug with Zoom sometimes. So we appreciate your patience, and we hope that this year we will all be even more patient because we do certainly. Thank you. Thank you all for joining us today. On behalf of my whole team, there are many of them you don't see right now, but we thank you very much, and we will definitely continue this conversation, which is very important. As you know, the Global Fund has started the Partnership Forum, in which many of you are attending. The Partnership Forum from many regions. Africa is next week, followed by Asia. So please, we hope that what you learned today about community engagement in malaria control and elimination will be very useful in the discussion during those partnership forums, but also at the country level when you are in your country and you want to also make sure that malaria programs are community centered and have a strong component of community engagement. So we'll make sure to share all of the content of this webinar with all of you. Like the latest Friday, you will receive everything in your email. And we look forward to continue to engage with all of you in this discussion. This is just the first one of the year, but we will continue to engage. And next time, we hope to have many more experiences from Senegal, from DRC, from Rwanda, from Asia, from many other countries. So we will look forward to continue this conversation and make sure we can all advocate and work towards a malaria-free world. Thank you very much. Have a good day.